I am glad to meet you, dear audience. My name is Cecan Mihaela, and today I would like to present you about the efficiency of scleral lenses. Scleral lenses corrects complicated corneal deformities, provides an optimal visual acuity even when other optical correction methods cannot. They are placed on the entire corneal surface and rest on the sclera. They transform an irregular cornea into a smooth optical surface. Scleral lenses are produced in the Sky Optics laboratory from different types of material. For example, Boston XO2, Boston XO, produced by Bausch & Lomb Inc., United States of America, Optimum Infinite, Optimum Extra, produced by Contamac Ltd., Great Britain, Acuity 200, Acuity 100, produced by Acuity Polymers Inc., United States of America. The lens rests on the sclera because of its diameter from 14.5 to 22 millimeters. It maintains a fluid reservoir called lens tear film between the posterior surface of the lens and the anterior surface of the cornea. Lens tear film has a protective effect on and optical function. The lens does not touch the surface of the cornea and does not traumatize it. Lens tear film excludes the deformed surface of the cornea from refraction, favoring a better vision. The advantages of scleral lenses include non-traumatic action of the cornea, for example at the tip of keratoconus, maximum oxygenation of the cornea, optimum visual acuity, high comfort, and thermal hues 1 year. Scleral lenses are classified into mini-scleral lenses that are suitable for patients with visible horizontal diameter of the iris lesser than 6 mm and the width of fixing area lesser than 1.5 millimeters, and large scleral lenses that are suitable for patients with the visible horizontal diameter of the iris bigger than 6 millimeters and the width of fixing area bigger than 1.5 millimeters. The given classification confirms that the choice of scleral lens diameter will depend on the visible horizontal diameter of the iris and the width of the limbus. Scleral lenses are indicated in irregular corneal astigmatism such as keratoconus, keratoglobus, marginal pellucid degeneration, in secondary corneal ecstasies, in post-traumatic keratitis infections, HSV keratitis, in degenerative corneal dystrophies such as Terian and Selazma. Indicated in high refractive errors, high regular astigmatism, aphakia, eyelid disorders such as ptosis, trichiasis, entropion, lag of thalamus, coloboma of the eyelid. Also, they are suitable for people that are working in dusty environments. Other indications include severe dry eye syndrome, Sjogren syndrome, Steven-Johnson syndrome, ocular cicatricial pemphigoid, chemical or thermal fuels, atopic keratoconjunctivitis, neurotrophic keratitis. First patients, male, 57, diagnosed with artifactia, high astigmatism, sequelae caused by penetrating trauma of the eyeball in the right eye. Visual acuity was 0.03. The refraction was 0.75 sphere and minus 6.75 cylinder, which didn't give us a better vision with spectacles, but with scleral lenses we got the refraction plus 0.25 sphere and plus 1.25 the cylinder, and the maximum corrective visual acuity reached 0.6. Here we have the corneal topography over the lens, where we see the uniform surface of the cornea. Next patient, male, 21, diagnosed with compound myopic astigmatism in the right eye and corneal glaucoma in the left eye. First, we had the visual acuity 0.5 in the right eye and 0.2 in the left eye. Here the astigmatism is compensated by the lens, and it gave us the maximum visual acuity in the right eye and the 0.8 visual acuity in the left eye. In the first image, we see the deformed cornea, and the second image is the corneal topography over the lens. Next patient, male, 49, diagnosed with corneal transplant with optical purpose in the left eye. In the first place, the refraction was minus 5.50 the sphere and minus 3.50 the cylinder, and the maximum visual acuity was 0.3. Over refraction, we've got plus 0 the sphere and minus 0.75 the cylinder, and maximum visual acuity. In the first image, we have the result of corneal topography without the lens, and over the lens it's next to it, where we see a great improvement. Next patient, A, age 27, diagnosed with keratoconus stage 2 in the right eye and keratoconus stage 1 in the left eye, both eye status after cross-linking. Initially, the visual acuity was 0.1 and 0.16. With optical correction, maximum corrected visual acuity reached to 0.3 and 0.8, whereas with the lens, the maximum visual acuity reached to 0.7 and 1.0. In the first image, we see the tip of keratoconus, and the second one is topography over the lens, where is a smooth optical cornea. The same results we see in the left eye. Next patient, D, age 21, diagnosed with keratoconus, stage 3, in both eyes, status after cross-linking. The refraction of the right eye was plus 8.5 the sphere and minus 12.5 the cylinder, and 0 sphere and minus 8 the cylinder in the left eye. Maximum corrected visual acuity was 0.2 for both eyes. Over refraction, we've got the visual acuity of 0.8. Corneal topography shows us the affected area of the cornea, and next to it, it's corneal topography over the lens. The same effect we observe in the left eye. And last patient, age 28, diagnosed with pelvic degeneration in the right eye, status after cross-linking. First, the visual acuity was 0.2 in the right eye. The astigmatism is compensated by the lens, and the maximum corrected visual acuity reached to 0.8. And here we have the corneal topography without the lens and over the lens. The purpose of the study was to evaluate the effectiveness of mini-scleral lenses in the correction of ametropia in patients with stabilized keratoconus. All patients were diagnosed standardly. The study included 68 patients with stabilized keratoconus after cross-linking. Stage 1 was registered in 16 patients, stage 2 in 28 patients, and stage 3 in 24 patients. All patients applied mini-scleral lenses for 12 months. The visual acuity of the patients had different dynamics depending on the stage of keratoconus. In patients with stage 1 of keratoconus, maximum corrected visual acuity with spectacles and with mini-scleral lenses had statistically similar values and constituted 0.96 and 1.0 respectively. In patients with stage 2 and 3 of keratoconus, on the contrary, maximum corrected visual acuity 3 months after cross-linking was statistically significantly higher in the case of scleral lens application compared to optical correction. The application of mini-scleral lenses also positively influenced the tear indices. Tear film breakup time increased statistically from 7.32 seconds to 10.6 seconds. The pictures show us the dynamics of quality of life of patients with keratoconus during the period of lens application versus the period without correction. Those important indices such as general condition, near and far vision, social interactions, and driving had improved. On the other hand, the psychological discomfort significantly decreased. In conclusion, the comparative dynamics of visual acuity according to the stage of keratoconus revealed that in patients with stage 1 there are no statistically significant changes between maximum corrected visual acuity with glasses and scleral lenses, which gives them a wider choice of optical correction method. The visual acuity corrected with scleral lenses in patients with stage 2 and 3 of keratoconus was 0.51 and 0.52 higher respectively than in patients who applied aerial optical correction. During the use of scleral lenses was recorded an improvement and stabilization of tear quality and quantity. Patient surveys showed a significantly higher level of quality of life when using mini-scleral lenses for the optical correction of keratoconus, with an average index of 96.6% compared to 59.3% for uncorrected keratoconus. Scleral lenses represent the most modern method of optical correction of keratoconus with contact lenses, which aims to achieve a maximum visual acuity while preserving the own cornea and postponing or preventing corneal transplantation in the future. Thank you for your attention, and I wish you a nice day.